So, hello, welcome to this webinar. So we are gonna start and then we can still have more people joining. So this webinar is presented by Professor Sébastien Soize. He is the head of the Interventional and Diagnostic Neuroradiology department at the University Hospital of Reims in France. And the presentation will focus on real-time perfusion imaging in the Angio suite, a new frontier for the neurovascular care. Just a few information before we start. So the microphone and cameras are turned off by default, just to minimize the interruption. But if you have any question, please feel free to write your question in either the Q&A area that is available at the top of your screen or in the chat, in the Teams chat, and we will submit the question and answer them at the end of the presentation. This webinar will be available on replay on YouTube next week, and on YouTube you can also find all our previous webinars as well. So thank you for participating, and I will let Professor Sébastien Soize start the webinar.
Thanks, Magali. So let's go. My presentation will be around 45 minutes. We're gonna see first a small background, and then how we can perform perfusion imaging into the Angio suite, how it works, what are the actual limitations, and try to work on these limitations to still got some good results, and what are the advantages you can have with the CBCT solution. First, obviously, to do it in the Angio suite, but also trying to explore the role of the advanced parameters. So let's go. So first of all, it's a small background just to discuss with you about the motivation of doing perfusion imaging on a C-arm cone beam CT. First of all, perfusion imaging is absolutely old, very, very old, and from the pre-thrombectomy era, even with nuclear medicine, from the pre-thrombolysis era in stroke, so it's super old. And finally, we already know that we can clearly, potentially well define the tissue that is still alive from the dead tissue. Actually, perfusion imaging the last years has grown of interest because there's much more patients that are arriving to the Angio suites with a lot of more late presentation patients. And we also got some publication. I just highlight one here, but we will talk about it with the advanced parameters of CBCT solution that can help going really deeply into the understanding of the physiology of the patient and where he is actually in his stroke. So as you know, we all got some workflow, typical workflow with the patients arriving to the emergency department, then comes to CT or MR, and then got tenecteplase or alteplase, and then finally go to the Angio suite if necessary. This workflow has not been changed for many, many years. And finally, while looking at this, we can understand that we can win 30 to 50 to 60 minutes if we try to skip the whole imaging part. Doing the imaging is not the biggest part, but all the transfers of the patients before and after are super time consuming. So finally, you can win about 30 to 60 minutes. And 30 to 60 minutes are between 10 to 40% reduction in functional outcomes. So it can be really, really important for the patients to try to save this time. Obviously, if you are registered to this webinar, you are already convinced that it can help your patients. And such kind of idea that CBCT can help the patient is not new. It's like almost 10 years. It started almost 10 years ago, only with plain CBCT and non-contrast CBCT and CBCT with injection to see the occlusion, either arterial or venous. But the perfusion idea is growing for just a few years. It started 10 years ago, but it really works since a few years. So finally, the direct to angio or the one-stop shop pathway is really interesting. You can save a lot of time. You can also save some money, have better results for your patients. And if you look at this meta-analysis, you can see that effectively with a direct to angio suite, without perfusion imaging, you save around 30 minutes, meaning with the perfusion imaging addition and the treatment, you may save 25 minutes. Something kind of real in real life is about this. So finally, when you go to this direct to angio approach, how can you use perfusion CBCT? There's plenty of applications. First of all, I go just again to repeat that there's one study that has been done with Siemens and not CERCare, but the Rapid software. And they were saying that you can win 29 minutes compared to a standard CTP protocol. The thing is, in such a study, you got a really, really low correlation between the CTP and the results of the Rapid software with CBCT, which is probably not the case with CERCare, which is much more reliable. So the perfusion CBCT can help you in selecting the good candidates for thrombectomy, replacing your standard perfusion protocol on CT or MR. But you can also have a second look to your patients. It's very interesting. We are treating patients in Reims that sometimes comes from 150 to 200 kilometers. So the time of transfer is largely more than 1 hour, and it's super interesting to have a second look before treating the patient, especially after thrombolysis. You can also select candidates for adding therapies or, on the contrary, stopping therapies during or after thrombectomy, meaning here the big point is looking at no reflow or failures. And you can maybe also estimate the risk of hemorrhagic transformation. So actually, let's see where we are, and we are here. So the news are the CERCare solution has been cleared by the FDA using only the Siemens synchodynamicity multiphase. It's reliable and useful to do perfusion imaging, and it's largely okay now with a study with 13 readers that have permitted this clearance. Actually, for Philips users or General Electric users, this is still an ongoing work. I'm a Philips user. We will see later that it's still possible, but improvements to come closer to Siemens are expected soon. Let's go a little bit deeper in the history of cone beam CT perfusion. So I showed you that now we can have such map like this, which are automatized with the CERCare solution. But it started like this with small region of interest, very small studies. Almost all the studies were done on Siemens machines, more or less old machines. This one is from 2022, and you got a small number of patients in this study. And as you can see, the correlation between MD-CTP and CBCT perfusion were kind of satisfying, but still very low. Another study also from Switzerland with the Rapid software this time, and Siemens have shown that finally, they got a good correlation for conventional CBF and multi-phase CBCT with different threshold, which is really important. When you use CBCT, you can use the less than 30% CBF threshold. You have to be more sensitive, you have to go up to 45%. Otherwise, there's too much discrepancy. But the correlation was still poor for mismatch volume. 0.33 is really low, and moderate for penumbra volumes. So there were, at that time, there was still some work to do to improve the correlation between CTP and CBCT perfusion. Another studies, again from Bern, on 19 patients on a bit newer Siemens machine. And they're trying to see whether improve the protocol, and they were still with a low correlation and a weak agreement for the core and the hypoperfusion. Definitely, when you look at the images, it's like MD CTP is kind of precise. CBCT perfusion is a bit more gross, but finally, the main information is not is it as beautiful as CTP or MR perfusion, but do I have my information, the one I need to take my decision. So let's talk a little bit about the challenges of CBCT perfusion in the angio suites. The main problem with such protocols are the very low temporal resolution compared to standard CT perfusion and the small sampling density. What does it mean? It means that you got 1 minute where you can acquire your CBCT perfusion images, and in that you need to have as much data points as you can. Actually, you can have, depending on the vendors, 6 to 10 data points per examinations. You are limited by the rotations of the tube, the angle that is the way the angle that is set at the beginning, and also the time of pause in between. So what is clear is that you cannot be waiting for such a smooth and beautiful curve as you got with CT perfusion. But with 5 to 10 time points, it's largely okay to derive a kind of very, very good curve, which is very close, not perfect, but very close to the CTP perfusion or MR perfusion. You got also other artifacts that can be super annoying. You got beam hardening artifacts, motion correction artifacts. We will talk also about specific artifacts due to the CBCT perfusion a little bit after. And actually, it was a few years ago, it was super time consuming for the post-processing, even more than CT perfusion. And now with the CERCAR solution, it only took a very short amount of time. So as a Philips user, I wanted also to talk a little bit about the additional limitation compared to Siemens. Actually, what you can have is 6 rotation, 1 non-contrast and 5 with contrast injection within 1 minute. Each rotation cost 8 to 10 seconds, and you got also time in between as pause. We are still waiting for some improvements. What you have to be aware of, even in Siemens, because you can say to me, like, why don't we do 2 or 3 seconds rotation acquisition so we can have like 20, 30 time points? But you don't have the same machine. You don't have the same tube, the same cooling of the tube also, the same angle of acquisition. With CBCT, you need at least to cover a certain amount of angle, otherwise your image are completely blurred. So these are the main limitations. We can improve these up to a certain point, but we will never reach the CTP or MR perfusion quality. Also, so as a Philips user, I was really interested in this CERCAR work, R&D work, So they try to see whether we can reduce the number of data points to see whether this is still accurate. What you can see is here you got right hemispheric stroke, MCS stroke. You got here the 10 time points you can acquire. And you got here your mismatch volume that is calculated. Penumbra is in yellow and the core is in purple. If you took only 5 time points, which are the pair time points, you got a map that is very close to the first one. So finally, this is really encouraging. But if you change your time points, you may go really, really far from what you were expected to have, and a very, very different mismatch volume. So finally, more than the number of points, what's really interesting is that the time where on the curve where your acquisition are placed is much more relevant and important. So finally, if you trigger your acquisition with bolus watching and then you launch your acquisition, you can expect to have something that is very close to the 10 time points. I'm going to show you a few cases to let you know how it works in practice. You've got a very old patient, 85 years old, with baseline NIH 12, left M1 occlusion. And here you got the MRIs at presentation at 4 hours after stroke onset with M1 occlusion, a big thrombus that is seen on the susceptibility images. Here is roughly your core, in fact, the occlusion. And this is the result of the circular perfusion CBCT we've done just 2 hours after arrival from the patient. So this was acquired in another center. And 2 hours later, the patient comes, the thrombolysis is finished, and we want to see what's happening. So finally, the patient has worsened. NIH is now 18. And we can see that you still got a low CBF with increased Tmax, which is a bit larger than the low CBF, meaning there's still some damaged tissue with probably a little bit of tissue to save. Then you can see CMRO2, OEF, CTH, and COV, which are the advanced parameters maps derived from the circular perfusion solution. I'm not gonna talk to this now, but because I'm gonna speak about it a little bit later. So let's have, at that time, we were not completely fixed about the threshold with the CBF and the Tmax we wanted to use. So as you see, we already discussed that if you took the same threshold as CB as CT perfusion, there's only 1 milliliter to save. And if you have the threshold we should use with CBCT, there's 7 milliliters to save. So it's not so much, but we've still done the thrombectomy. The occlusion is here. There's good collaterals. We've done just an aspiration. The clot is here. The catheter is here. And finally, the patient is fully reperfused with a TK-free recanalization. Finally, we can see just a small drop initially of the NIH from 18 to 16, and then at 24 hours to 10, probably well corresponding to the small amount of tissue that we can save, that we were expected to save. Another case, younger patients, male, thrombolysis has been, thrombectomy has been done the day before, and he had transient ischemic attack the day before, and now he's NIH 11 with a tandem occlusion. The MRI is done 3 hours after symptom onset. We don't see carotid and MCA on the right. The patient was super long to come because he was at 200 kilometers. So we've done a new evaluation. So we've done a CTP that you got here on a General Electric emergency scanner. with the CBF, which is kind of the same as the core on the DWI, and there's still plenty of tissue to save with big penumbra on the Tmax. 15 minutes later than this CT, we acquired a second perfusion map while the anesthesiologists were preparing the patient. And what we can see is we have kind of the same maps as we can derive from a standard CT perfusion. We can see the CBF area, which is almost the same, and the Tmax, which is almost the same exactly. Be aware that the two, I do not compare perfectly. We are at the upper level on the CT than on the CBCT images, and the non-contrast CBCT. Sorry, the control CT after recanalization is here and correlates perfectly with the CBF that we had to, after the arrival of the patient. And sometimes you can see such patient M2 occlusion, this kind of small stroke, not so big. We try to do a CBCT perfusion, and oh my God, we got like this. We got lines, not interpretable perfusion, so we are kind of annoyed. It happens sometimes. This is so-called the limited view artifacts. These artifacts are, we know that this is clearly the limitations sometimes of the CBCT due to a small angular coverage, meaning it will not be a problem with the same protocol in all patients. Like, it just happens sometimes because the bone of the patient is too big, the head is not perfectly spherical, the patient has not removed some earrings, so there's some metal, or even you got also the teeth that can sometimes provide some problems. So finally, we know that it exists. And if we know that it exists, we know why. It exists because sometimes the field of view is too large. Sometimes the exomass is too big. The exomass is everything that is around the head of the patient. So in an intubated patient, you forget to remove the earrings, you're in the worst condition ever. If there's some metal presence, sometimes it's just a probe from the anesthesiologist, something that is here and you don't see, or a cable, and that can create such kind of artifacts. If there's a big cortical bone, especially in some female with big frontal cortical bone, it can create some problems also. So my practical feedback is that you have to be perfectly prepared to limit these artifacts. So to limit these artifacts, here you can work as, actually, we got a protocol and we are discussing with Philips to try to have two protocols, and one to reduce the field of view. So we can exclude directly the exomass, and also try to increase a little bit the mass. Okay, so you increase the dose finally, but it can really help to overcome such artifacts. Also, you got to train your team, like the Ferrari team or every Formula One team, to remove every metal around the head of the patient, optimize all the head environment, the headrest, gels, remove every probes from the field of view, try to secure the head, attach it firmly, and also be aware that general anesthesia, and you got plenty of tubes, and sometimes it can create artifacts. In Philips, but it's also true probably in Siemens, but I will only speak for Philips, perform your machine calibration daily is super important, because the quality of your CBCT can decrease quite rapidly if you do it just once a week or once a month. And you can create some kind of targets, artifacts in the middle of your scan. and train your staff without the patient. It's really important just that anyone got his own checklist and be aware that they are really prepared. Some kind of thing we can discuss to improve the CBCT perfusion is to use also some advantages of the Philips machine. It's in discussion. We are not sure that it can be used and improved really a lot, but you know, we got this kind of weird acquisition with a butterfly movement. It's not so slow compared to the standard protocol, not slower, not longer, but finally it's 7.8 seconds actually compared to 8 seconds, so it's almost the same. But you got really, really better image quality. Actually, you can see here an embolized patients on top without butterfly. So conventional helical acquisition, and on the bottom, it's the butterfly acquisition. Here you can have also the comparison with, on the left, 4 images of acquisition of the basic low dose protocol from Philips Perfusion, and on the right, a scan that we performed on with the butterfly with almost no artifacts, much more resolution. We also got the dual phase acquisition, which is one of the way we can solve some problems, meaning this is actually how it works on Siemens machine. You go one way with your acquisition, you got a 1 to 2 second pause, and then you go the other way with another acquisition. So you save a little bit of time. You have to be aware that the constraints to your X-ray tube can be higher than conventional acquisition just on one way. Actually, if you think about the dose you deliver to the patient, the dose are used to be with old machines a little bit higher than CT perfusion, but now with the new Siemens protocols and Philips protocol, we are really, really close to a standard CT PEEP protocol. There's a difference. The difference is a larger field of view, which is a constraint for having, so you get less beautiful images, but you got a whole brain coverage that you don't have with a standard CTP protocol. I can skip this one. So finally, the future is kind of bright. As I said, there's still some applications for stroke that properly work. You can also probably go for research and find with the advanced parameters some ideas. We got some ideas to predict hemorrhagic transformation. We are kind of working on vasospasm actually also, and using it for some patients. And we plan to use it also for some patients with aneurysms treatment in specific cases. So actually, I'm just going to talk a little bit about how CERCare parameters can help you. So as you see, this is the same case we saw a few minutes later. With this, now we are going to talk about the advanced maps. The first parameter, which is to me the most relevant, is the CMRO2, cerebral metabolic rate of oxygen. Finally, you have to understand really easily that it's the rate at which the brain tissue burns your oxygen. So if it's really low, it burns the oxygen, there's no more oxygen. It's your metabolic activity. So finally, this may be a much more reliable parameter than just the CBF for assessing the viable tissue, so the penumbra. It means that this has been done with CT and MR perfusion, not with, it has been proven, but not proven for CBCT. But we probably can derive it and use it and assess. As you see, you got a difference of threshold with the RCBF. So we are kind of working also on trying to search some better threshold with the CMRO2 that can replace the actual 45% CBF that is not fully satisfying. Just a small case. This is not a CBCT perfusion, but it's just to show you the maps and the CMRO2 that is most of the time really close to the CBF maps. A publication on a with CERCA users from Korea that has shown that finally you can have an optimal threshold of 25% for CMRO2, which is kind of close to the 40% with CBF, but you got really, really less bias of assessing the volume of your current penumbra using this parameter. So finally, you see you got, if you stay with your CBF, you got much more, you got 14 milliliters of variability compared to using CMRO2. So you're closer to the truth with CMRO2. The second parameter is oxygen extraction fraction, which is finally the oxygen that is extracted from the blood to perfuse your tissue. So this really reflects your compensation, your actual compensation. At the beginning of your stroke, your neurons kind of try to survive and try to extract, meaning you got a low CBF and a low CMRO2. There's no more oxygen in the area, but they try with the hardest way to extract some oxygen. So at the beginning, you got, like here, an elevated OEF, and it's a good sign, definitely. When your OEF is really low, it means your brain abandoned and the tissue is fully dead. So finally, what I remain here is that OEF complements CMRO2, and it's kind of showing like when there's a metabolic failure and your brain simply let go and the tissue is dead and it's finished. When you got an elevated OEF, it's a good sign that there's probably inside some tissue to save. And beyond the tissue that is being able to be saved with the penumbra, there's plenty of definition of the core and the penumbra. Usually, most of people use the definition of DWI positivity or the CBF less than 30% in CT. But finally, what this study from the Lyon team showed is that you can have a patient with a DWI lesion with elevated OEF and very low OEF, two patients. The one with elevated OEF may have some chance that more of the DWI can reverse. With low OEF, I said that your brain already abandoned and the tissue is dead. And it's interesting. 11 years ago, I've worked, this is the top figure, about DWI reversibility after thrombolysis. And it's really interesting that we know that if we go fast, recanalize the patient fast, some of the DWI lesion can go away, restore, and be sustained. And it's really interesting that with the OEF, it confirms this, but also you can be able to see, even sometimes with CT, that or if you do MR, it's okay, but also if you do CT, you got a normal CT, you got very elevated OEF and a big Tmax like on the patient on the top, it's a really good sign that you can save a lot of tissue. Third parameter is the capillary transit time heterogeneity. It's a much more complicated parameter. Finally, it looks at the heterogeneity of your mean transit time, meaning not only the voxel you're analyzing, but the voxel around. You are looking at your voxel and the voxel around, and you see whether the mean transit time is the same or super different. If you got super different mean transit time in different areas that are quite close, it probably means that there's a poor microcirculation, capillary dysfunction, low oxygen extraction, and finally, no reflow lesions. So finally, the CTH reflects the quality of your microcirculation. There will be probably some future study on that. Doing CBCT after recanalization and see whether we still need to go further with intra-arterial injection of some thrombolysis, like recently the CHOICE-2 study highlighted the benefit. So the no-reflow phenomenon is not super frequent. It's less than 10% of the patients. But finally, you see you can got microvascular occlusions, stayed neutrophils, vascular remodeling. And finally, we don't care. What we want is just to see whether it exists and if we need to give additional therapy to the patient or not. So we are not able actually to see whether it's microvascular occlusion or some blocked neutrophils. It can count about on the therapy we want to provide, but actually, even recently, there's the CHOICE-2 study that showed that even patients with a good reperfusion may benefit from such injection, intra-arterial injection of thrombolysis to remove such microvascular occlusions. So we can be able to witness this phenomenon and the benefits with such parameters. The last one, which for me is a little bit more complicated and probably with CBCT a little bit less useful, is the COV, variation of transit times. It means that it's even further than the no reflow with the CTH. And if you got a high COV, you got just an unstable microcirculation. And if it's a low COV like here, you got kind of good capillary network. So it's complementary to the CTH. Actually, it has been less explored, but it should be to see whether it can help also to define if there's some microcirculation injuries or misfunction. Here is a small summary. Finally, you can use CMRO2 for the viability assessment of the brain. OEF is a marker of your compensation. CTH is your microvascular efficiency, so the microcirculation, and COV is kind of close to the CTH, is the microvascular stability. So I told you we were using this also for other applications. I'm just going to show you one case. This case was a patient with right MCA vasospasm after subarachnoid hemorrhage that has been embolized. And here we see that there's a small penumbra. There's a small core and a small penumbra before chemical dilatation. We had a quite good improvement at the end of the angio, but we were not perfectly convinced that the arteries were like they should do. So we were wondering whether we need to do a complementary medical dilatation of the MCA or not. And finally, we did another CBCT perfusion. So we got 2 CBCT perfusion on the same patient, and the blood flow has been restored. It's largely, we were largely confident that now we can stop the procedure without trying to do some probably a little bit more dangerous mechanical dilatation. Thanks for your attention, and I will welcome your questions now if you want.
Thank you. Thanks a lot for this presentation, Professor Soize. It was very insightful to hear this presentation, and it's particularly interesting for us to hear your perspective of the clinical application for the future of the CBCT perfusion. And if you have any question, please feel free to submit the question. So we have the Q&A that is available at the top of your screen, but you can also write the question in the team chat. So if I may, on my side, I do have a question for you, Professor Soize. So I'm going back to the beginning of the presentation when you were talking about the current approach for triage of the patient. And I was wondering, in your current stroke practice, in which subgroup of patients the CBCT imaging perfusion would make the most difference for you? at the moment? Would it be for the wake-up stroke, maybe for the large core patient, for all of them? What would it be for you?
As I'm super convinced, probably all of the patients. But actually, it can really be useful for centers with very long delay transportation of the patient for reassessment. Honestly, it's very useful. But you can use it for every patient. You can save 30 minutes. So you can save it's super interesting. You can save more than 10% of good functional outcomes. So you can improve your numbers of good functional outcome without changing your practices in the Angio suite, or almost. You do the same thrombectomy, but you can 10% with better results. So at least for me, it's all patients.
Thank you. Thank you, Professor Soize. Let's see if we have some question. Please also note that this webinar, the replay of this webinar will be available on YouTube sorry, I'm starting again. So next week, the replay of this webinar will be available on YouTube. On YouTube, you can also find the recording of all of the previous webinar that we had this year, but also previously. And if you are not already following our LinkedIn page, please, we encourage you to follow the LinkedIn page so you can stay up to date with our latest news on CBCT, but also on our upcoming webinars. Thanks, thanks you to everyone for, thank you to all the participants, and thank you again, Professor Soize, for your very interesting webinar. Just a question, we just received one. Is that the CBCT perfusion validated as aggressively as rapid perfusion system?
Is it validated with rapid, right?
Validated as aggressively as a rapid perfusion system. So this question comes from Zhu Jindong. So if you maybe can give you more information on your question.
I have to perfectly understand the question. If you can even discuss, yes, I will be happy to discuss with you. Tell me exactly what you mean by this, please.
Right. Thank you. Thank you for the excellent lecture. So just question, we are using a rapid system in the US, so is in the CT suite. So you are providing a new sort of device in the Angio suite with a CBCT perfusion. So is that a CBCT perfusion validated aggressively in the as the rapid system we are using very very popular right now? We are not doing too much CBCT perfusion in the Angio suite. Just try to see how that mismatch is validated enough so that we can reliably using it.
Okay, I have to be cautious with my answer because as I showed you, there's actually very few studies with rapid software for CBCT, and it has been done in the best condition possible, meaning it was done during the development of the Siemens Dynacity and specific for perfusion. So they were in the best condition. So honestly, it can be validated some kind if you do it the best way with Siemens. If you got some still some work like with General Electric or Philips, and also so the first point is it may not be validated with all the manufacturers of Angio suite. It's possible to do it with Siemens. There's no direct comparison actually. We should do this probably. I believe that probably the advanced parameters of CERCA are a little bit more accurate because they are more accurate on CTP. So the CERCA solution is actually validated in the States only for Siemens user. It works perfectly. it's automatized. With Rapid, I think it's still research. I really don't know if you can translate your images from your PACS or directly your Angio suite to the Rapid software. I'm not sure it works for everyone, actually.
Mm-hmm. Mm-hmm. Yeah,
and there's probably some validations work to do. As I said, the threshold of 45% is the best we got now, but you may have some big discrepancies, like for some patients, more than 20-30% of the penumbra volume with such threshold at this time.
Mm-hmm. Mm-hmm. Yeah, I understand. So yeah, I think right now we try to, I mean, if we try to bypass the CT suite and directly send the patient to the Angio suite, we try to see whether there's any like head-to-head comparison between the CBCT perfusion system with the other like CT perfusion system to see whether they are the mismatch could be generated for more use for the Angio suite CBCT. Yeah.
As you saw in the Rapid study, they found a really low correlation for. So that's the thing is there's already a difference. There has been some studies that has been published between Rapid and CERCA that CERCA is a little bit closer, but significantly closer to the truth, to the ground truth than Rapid is for the estimate of the core and the penumbra. And then after, if you translate to CBCT, so in kind of low quality images, you have to try to be in the best situation possible. So for me, I'm a Philips user, so I'm not in the best conditions. But if you're a Siemens user and you got Siemens and you got CERCA, you're in the best condition ever. If you got Siemens and Rapid, you may be in kind of acceptable conditions. Gotcha. Otherwise, it may be difficult.
Perfect. Gotcha. All right. Thank you so much.
So thank you again, and thank you for your for being here with us, and thank you, Professor Soize, again. Thanks.
Have a nice evening, everyone. Bye.